Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. This is Cardiology Seminars brought to you by Triple N Media. Our YouTube channel has more than 200 lectures in cardiology. We welcome you to watch them. We also kindly request you to subscribe to our YouTube channel. I also have a cardiology rotations manual for students, nurses, residents, and fellows to enhance your learning experience during your cardiology rotation. And I'll tell you how you can get a free copy of this book at the end of this presentation. The featured presentation is heart murmurs. I have done a video on jugular venous pressure, pulsus paradoxus, arterial pulse. I also have a video on chest examination. And now we're going to talk about heart murmurs. Heart murmurs are created by turbulence, which is due to variation in the blood flow across heart valves, chambers, or blood vessels. Any conduit where the blood is flowing, whenever there is a change in the size or the resistance, you're going to get turbulence. The turbulence results in a murmur or a thrill. It is also related to the resistance and the volume of blood going through an existing conduit or pressure differences across different chambers. The murmurs can be systolic, diastolic, or continuous murmurs. Systolic murmur can be in the early phase of the systole, or it could be in the mid-systole, or it could be in late systole, or in some cases it could be pan-systolic. We're going to find out what these conditions are. Similarly, the diastolic murmurs can be in the early diastolic phase or in the mid-diastolic phase or in the late diastolic or pre-systolic phase, like pre-systolic phase here. And sometimes we get continuous murmurs, like in patients with patent ductus arteriosus or any other situation where there is continuous flow, like AV fistula. And it is very important to understand the cardiac cycle in order to appreciate the origin of the murmurs, the location, the quality, radiation, and grading based upon the cardiac cycle. So when we are listening to the heart, normally we should hear just the heart sounds. If you hear anything besides the heart sounds, like lapsh, 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 or lapsh, dup, lapsh, dup, that means you are dealing with a murmur. The first thing you need to do is the location of the murmur. In what area of the heart do we hear this best? Is it the apex? Is it at the aortic level? Is it at the pulmonic location? Is it at the tricuspid valve location? Then the quality of the murmur. Is this harsh? Is this soft? Then grading. How loud is the murmur? Is it very faint murmur? Or is it, you can feel the thrill when you put your hand here, like in patients with critical aortic stenosis. Then the pitch. Anything that has high velocity or high pressure system, it creates high pitch. Anytime there is a critical narrowing, it creates high pitch sounds. Anytime when there is a leak, they usually result in a low pitch sound. Then timing in the cardiac cycle, as I said, is this in pre-systolic, early systolic, mid-systolic, late systolic, or diastolic? The duration of the murmur, like the aortic stenosis murmur, is crescendo, decrescendo, that is shh, 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 whereas mitral rigors or tricuspid rigors murmur shh, 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 continuous, sort of holosystolic. It lasts through the entire systolic phase. Shape of the murmur, as we draw a phonogram, you see the shape of the murmur like an audio recording. Then changes with respirations, position, and drugs. Okay, let's begin with the systolic murmurs. Early systolic murmurs. They are usually related to pressure differences across two chambers, like in patients with mitral regurgitation, ventricular septal defect, tricuspid regurgitation, or non-restrictive pulmonary hypertension. We are going to see an early systolic murmur. It is not only early, it is also mid and late systolic, so it becomes a pan-systolic murmur. But if you hear this murmur starting with the first heart sound, then it is an early systolic murmur. And if it lasts through the entire systole, then you're talking about mitral regurgitation or tricuspid regurgitation, or it could be VSD. Again, with VSD, it depends upon how quickly the left ventricular pressure normalizes with the right ventricular pressure. If the right ventricular pressure equalizes the left ventricular pressure, then we don't have any more murmur. Now let's talk about the mid-systolic murmur, which is the most obvious one, which most of us know, and that is the ejection systolic murmur we hear in patients with aortic stenosis. It begins a few milliseconds after the first heart sound. If you go back to the volume curve here is the atrium and here is the closure of the mitral valve, but it takes some time for the valve to reach the pressure beyond the aorta for it to open. That's when we're going to be hearing the murmur. So there's going to be 40 to 80 millisecond delay before the beginning of this systolic murmur. Then it is a crescendo, it's a crescendo, decrescendo murmur. Like that. Seen in patients with aortic stenosis, coarctation of aorta, and it can also be seen in patients with sclerosis, aortic sclerosis, or even hypertension. Subvalvular, you're quite familiar with the aortic subvalvular membrane or tunnel or hypertrophic cardiomyopathy. It can also be seen in patients with hyperkinetic state, aortic regurgitation, complete heart block, and may also be seen in patients with dilatation of the ascending aorta. Supravalvular, mostly we see this supravalvular, which is uncommon, though not rare in aorta to have a membrane, but more often we see a supravalvular membrane on the right side. We can also have subvalvular infundibular stenosis, that is the obstruction to the outflow tract of the right ventricle, which can cause systolic murmur. And of course, in patients with left to right shunt, because of increased volume, because of increased pressure, we can hear a mid-systolic murmur. Let's look at the next one. When we are talking about these ejection murmurs, particularly aortic stenosis ejection murmur, it is graded based upon its intensity. Grade 1 is faint, barely audible. Grade 4 is an audible murmur with palpable thrill. So this is how I would like to break this down. If you have a thrill, it is grade 4, 5, or 6. If the murmur is loudest but no thrill, it is grade 3. Grade 2 is between grade 1 and 2. Grade 1 is barely audible, whereas grade 5 is loud murmur, audible with a stethoscope lightly placed on the chest. And grade 6 is where you can hear like, where it is audible even with the stethoscope not even touching the chest, just holding it close to the chest wall. You should be able to hear that one, and it's usually radiating to the neck. Now let's talk about late systolic murmurs. Where do we see late systolic murmurs? Late systolic murmurs happens in patients with mitral valve prolapse or tricuspid valve prolapse. That is because initially the mitral valve leaflets close all right, but with continued systole, we have the prolapse of the leaflets causing this mid-systolic click and late systolic murmur. Holosystolic is the one that lasts throughout the entire systolic phase, which I already talked to you about, which includes mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. Let's talk about diastolic murmurs. Early diastolic murmurs are heard usually in patients with aortic regurgitation. Why do we hear the aortic regurgitation murmur at the early phase of diastole? That's when as soon as the ventricular pressure begins to come down, the aortic valve closes. But if the aortic valve is not competent, if it's fixed and if it's immobile, the blood can leak. So it leaks right after the second sound, causing the early diastolic murmur. And it is sort of a decrescendo type of murmur. It's a soft murmur. It is also seen in patients with pulmonary regurgitation. It may also be seen in patients who have dilated aortic root for the same explanation, or aortic dissection, which can alter the physiology of the leaflets, cystic medial degeneration, and widening of the commissures. Pulmonic regurgitation, it can also be seen post-valvotomy in patients who had valvular interventions or endocarditis, rheumatic fever. Dilatation of the pulmonary artery and the annulus. Marfan's patients who have dilated aortic root may stretch the aortic root and cause valvular incompetence, leading to early diastolic murmur. Tetralogy of Fallot, VSD, and pulmonic stenosis are other conditions that can lead to early diastolic murmurs. Now let's talk about the early diastolic murmurs. Begin with the second sound, and they are decrescendo murmurs. Now let's talk about mid-diastolic murmurs. The most obvious condition is a mitral stenosis, which has an opening snap after the second sound when the mitral valve tries to open during the early filling phase. Then we have the mid-diastolic rumble that can be followed by a pre-systolic accentuation. So that is the mid-diastolic rumble. It is seen in mitral stenosis. It is another condition called Carey-Coombs murmur, which is mid-diastolic apical murmur heard in patients with rheumatic fever, which we rarely see these days. It can also be seen in patients with mitral regurgitation due to increased flow across non-stenotic mitral valve. Anytime a flow is increased, there is sort of a physiological narrowing of the orifice to accommodate the volume. That's why we can hear murmur in anemia, thyrotoxicosis, pregnancy, which may correct after the conditions are resolved. Same thing, high output states like patent ductus arteriosus, tricuspid valve stenosis, which is also very uncommon, but it can be seen in patients with rheumatic fever, increased flow across non-stenotic tricuspid regurgitation, ASD, anomalous pulmonary venous return. All these conditions can cause mid-diastolic murmur or rumble, as it is called. Now let's look at late diastolic murmurs. Here we have the patient with the diastolic phase. We have the second heart sound, opening snap, followed by mid-diastolic rumble and pre-systolic accentuation. That is in a patient with significant or critical mitral stenosis. So late diastolic murmurs can be heard in patients with mitral stenosis. It is also heard as Austin-Flint murmur of severe or eccentric aortic regurgitation, patent ductus arteriosus, coronary AV fistula, and a whole host of these conditions, atrial septal defect, anomalous left coronary artery, proximal coronary artery stenosis, a whole bunch of conditions. You can just look through this, but they cause late diastolic murmur. So ladies and gentlemen, just to summarize, when we are focusing on heart murmurs. We need to first location, then the quality of the murmur, grading, the pitch or the intensity, timing in the cardiac cycle, duration, radiation. For example, the mitral regurgitation murmur radiates to the left axilla. The aortic murmur radiates to the neck along the carotids. Shape of the murmur and changes with respirations. Thank you so much for watching. We have more than 200 cardiology lectures on our YouTube channel, and we welcome you to read them. I also kindly request you to subscribe to our YouTube channel. This presentation, the cardiology seminars, have been brought to you by NNN Media. I am Dr. Nik Nikam, a cardiologist from Houston. Thank you so much, and please do subscribe to our YouTube channel, and I will see you next time.